Hi, this is Brian Kim. I'm going to share with you case number 107 in the best way to do cataract surgery series. This is a patient with a very dense lens, a Catarock, and then there is a focal area of Iris-Corneal adhesion, and I'll be performing the modified stop and chop, the terminal chop technique, double chop, cross chop, mechanical fracturing techniques, and show how I'm able to tackle this very dense cataract by performing these fracturing techniques to minimize ultrasonic energy use and hopefully to achieve clearer corneas and reduce the risk for complications. So I'm using a cotton tip to straighten the eye, and then I'm using a corneal marker which will help me to center and size the rhexis. I'm making a paracentesis incision first on the right side and then the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. Upon first glance, this may appear to be a posterior synechiae with an iris adhesion to the anterior lens capsule, but this is actually an adhesion between the iris and the cornea, which explains the area of focal edema. And so I tried to use the rhexis forceps to try to pull it off, and that really wasn't very hopeful at all. So I switched to the cystotome and I puncture and cut to the left and then create a nice little flap, which is pointed towards the right. Go in sideways and grasp the flap, go around circumferentially, and try to follow the corneal mark that I made to hopefully allow me to achieve a well-centered and sized rhexis. Finish off the rhexis. And this is the capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the cannula tip down, get a nice fluid wave, very gentle wave, decompress on the left side, turn the tip to the right, and then the lens begins to spin. I'm able to use the cannula to hook the peripheral lens when I do that. Just using some more viscoelastic to coat the corneal endothelium. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. I'm going to turn my phaco tip, first bevel down, removing the surface epinuclear material. And then I'm going to turn it bevel up, placing the chopper in, and then I'm going to start to sculpt. This is a very dense lens, and I want to debulk the lens as much as possible. And this is where there's maximum coating of the corneal endothelium with viscoelastic. So this is really the ideal time to really sculpt that trough in the middle. And by debulking that endonuclear material, this reduces the chances of having that posterior plate. This is quite a bit of a dense lens here. Try to use enough energy so that I'm not pushing on the lens. So when I'm satisfied, I turn it bevel down, switch to quad mode, place the chopper out to the equator. And this is that terminal chop technique. I fracture it from the equatorial side, and the fracture propagates all the way across. I'm going to rotate it 180 degrees and perform the same maneuver on the other side. Place the chopper around the equator again, and then perform that same maneuver. Now, there's two very clearly separated heminuclei. Place the chopper around the right heminucleus, pulling it centrally toward the phaco-tip. The phaco-tip is deep. Crush the lens against the phaco-tip with the chopper. I'm able to lift that first quadrant up with some vacuum, crushing it, and then emulsifying the lens piece. Rotating the second quadrant in front of me, separating it with some mechanical forces, placing the chopper around the lens piece, dividing the second quadrant, using some vacuum to lift that piece up, crushing it between the instruments, crushing it some more, and then emulsifying the lens pieces. Grabbing that piece with a little bit of vacuum, crushing it between the instruments, crushing it again, and then emulsifying the lens pieces. So half the heminucleus is gone. I turned the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco-tip, which is positioned deep in the back. Separating the lens pieces, there's some adhesions there. Placing the chopper around the third quadrant, pulling it centrally towards the phaco-tip, crushing and dividing the lens piece, and then separating the pieces, using some vacuum to hold that one fragment, getting around it with the chopper, crushing it, dividing the lens into smaller pieces, and then emulsifying the lens pieces. Placing the chopper around that lens piece, grabbing it with a little bit of vacuum, crushing it into smaller pieces, and then emulsifying the lens pieces. By crushing it into smaller bite-sized bits, I'm able to use less ultrasonic energy. So this is the last quadrant. Getting the instruments around the lens piece, using some vacuum, and then crushing it in half, using some vacuum to hold it again, crushing it again into smaller pieces, and then emulsifying the lens piece. This is the final fragment. There's a nice bit of epinucleus here, and so you can see, even though I'm protecting the posterior capsule with a chopper, that robust piece of epinucleus is enough protection. So I use some vacuum to grab the epinucleus here. It prolapses up pretty easily. So I take the chopper out, push BSS in, take the phaco-tip out, and I go in with the INA handpiece, adjusting the sleeve, making it closer to the tip. Starting subincisionally, I'm grabbing the subincisional cortical material, sweeping side to side. You can see there's some puckering up the posterior capsule here. Trying to go around circumferentially, very carefully grabbing the cortical material and trying to avoid grabbing the capsule there. Switch to polish mode, polishing under the rhexis edge. Polishing the posterior capsule surface, polishing under the rhexis edge again. The pulse into the subincisional space with the BSS cannula. You see a little bit of material being liberated with that maneuver. Filling the bag with cohesive viscoelastic, using the sweep to sweep underneath the rhexis edge. First on the left side and then the right side. Since this is a dense cataract, I'm going to put a 3-piece lens in. So I'm using a blade to widen the incision. getting the injector right around the lip of that triplanar incision that I had to make. Because it caused viscoelastic to come out, I push some more cohesive to fill the bag, deliver the leading haptic into the bag, rotate my wrist counterclockwise to allow the optic to come out correctly, and then deliver the trailing haptic with the Maltzman. So I go in with irrigation off, activate irrigation, go under the lens, remove the viscoelastic from within the bag. Again, because I widened the incision, there's going to be less chamber stability in this situation. You have to be mindful of that. Removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a very dense cataract. This is a Catarock. You saw there's an iris adhesion to the cornea causing some focal edema. I performed a modified stop and chop, which was called terminal chop, where you don't fracture from within the middle of the crevice. It's rather inefficient because you're trying to approach it from the top and the bottom is still attached. So if you approach it from the equatorial side, you can propagate a fracture along the equatorial plane, almost like a fracture point when you have an earthquake or something like that, instead of trying to approach it from the top. This is the most efficient way, in my mind, to debulk as well as be able to fracture the lens in half in these very dense lenses and to avoid getting that posterior plate. After that, it's really doing a bunch of cross-chop maneuvers to fracture the lens pieces and dividing them into smaller and smaller pieces, doing mechanical fracturing techniques to crush the lens into smaller pieces, into bite-sized pieces, which again reduces the usage of ultrasonic energy, and in my experience, clearer corneas that occur much more quickly with this technique postoperatively. So I hope this was helpful to you, and I thank you for your attention.